Hey, Dr. Bhinder, how's it going?
Hey, good. How about yourself?
Good, thanks. Long time no see.
I'm I'm waiting. I can't see if I'm in the right meeting or not. We'll see.
Okay.
Yeah.
This was the
Wait,
link that was
yeah.
sent to me by, I guess, Megan Smith.
Yeah, and this is the same link that I have as well.
Okay.
So yeah, so I think we're in the right one. Usually everyone joins at around like right at 12.
Okay. Yeah, I figure usually it starts, probably 5 minutes after that while people are just trying to get themselves sorted out.
Yeah.
Do you have the deck? Do you have everything that you need?
I do, yeah, yeah,
Okay.
yeah. I mean, yeah, I've spoken to this group before, so it's a deck designed around asthma, COPD, and that journey. So it's relevant to the hospital physicians and to our Dupixent multidisciplinary. So yeah,
Fantastic. Okay, that's great. I know Peter's off.
yes, he's
Yeah.
in. You know what? He sent me a text message. I haven't had a chance to reply. He is away.
Yeah, I think he's actually at the Masters.
He is. Yes.
Yeah. So
Yeah.
I think he won the lottery there to get the tickets. I'm not a big golfer, so I know it's a big thing, a big event, but
Yeah.
I know it was on his bucket list of things to do.
Yeah.
Are you a big golfer?
I used to play when I was in elementary school and high school, and
Yeah.
then I stopped when I went to U of T at 19, and I just never picked it up then.
Yeah.
Yeah.
It
My
takes a lot of time, eh?
takes a lot of time. My last two rounds though were 74 and 76.
Are
So
you
I
serious?
yeah, but I used to play every day. In high school in the summer, I would just play every day.
Jeez.
Yeah, but I just stopped and never had time. Kim and I tried around the time of 2015, but it just
Yeah.
never. Yeah, it was just a a commitment. So yeah,
Yeah.
yeah.
Well, it makes it a bit easier if your wife kind of gets into it, right? So, oh, I think someone just popped in and popped out. Dr. Bennett, do you know the group or do you know who is the one that's organizing this?
Yeah, it's Megan. But this is our Department of Medicine grand rounds for the entire hospital.
Okay. Okay.
So every division, but also our allied health colleagues, our pharmacy colleagues, everyone joins in,
Fantastic.
and meant for the entire hospital. So it's recorded, and it will then also stay for review by our colleagues later on as well.
Okay, that's great. So anyone who is not able to make it can catch the recording.
Of course, yeah,
Okay, fantastic.
yeah. All right, I will get my slides loaded up, and then we'll wait for everyone to file in.
Fantastic. All right, great.
Hello, Dr. Bhinder. Sorry, I heard you at the very beginning for your intro. We're looking forward to your talk today.
Excellent, excellent, Swasti. I'm looking forward to it as well.
I'm sure a few pharmacy people will be coming, so we'll see them soon. Thank you.
You're welcome. All right, folks, we are at 12:02. I'm going to wait till about 12:05 and then get started. Now, I always worry that my audio isn't projecting, so if someone can just let me know verbally that audio is good, I will sit tight for 2 minutes.
Audio's working.
Fantastic.
All
Thank
good.
you. All right, folks, we're looking at 12:05, so I think I will get started. I know that our colleagues will trickle in, and of course, this is being recorded so that it will be accessible to view after the fact. In the past year, I've spoken to our Department of Medicine and our allied health colleagues on asthma in the modern era, 2025 into 2026, COPD in the modern era, and I thought it might be an opportunity to revisit this, but under the umbrella of a unifying cause and a unifying pathway. We're talking about T2 disease here. The title, Thinking Beyond Asthma and COPD. Now, when I think of T2 disease, what I do think of is Arnold from the movie Terminator 2 Judgment Day, which was released in 1991. This 2026 will mark the 35th anniversary of Terminator 2 Judgment Day. Pivotal movie for Arnold's career, turning him from the villain to the hero in this movie, and a new arc for his career, his life in general, but also a turning point for asthma. 1991 marked the first asthma education and prevention program from the NIH guideline, which placed inhaled corticosteroid front and center for management of inflammation. Prior to 1991, prior to those guidelines, asthma was a disease of symptoms. We targeted symptoms with short-acting beta agonists. We targeted a higher burden of symptoms with more short-acting beta agonists. Remember, we did not have Singulair. We did not have long-acting beta agonist. We gave patients more high-dose inhaled steroid. We gave patients oral steroid. We managed theophylline, and we managed theophylline levels in patients with asthma, but high-dose inhaled and oral corticosteroid were the treatment options available to patients. But it was a disease of symptoms, and inflammation was ignored. 1991, the start of Terminator 2 Judgment Day era in the modern icons of film history, and also the first guideline by the NIH placing ICS front and center for management of asthma inflammation. I'm going to show you just how far we've come in terms of understanding asthma pathways and what modern biologic therapy can do to reverse that clock of inflammation, unravel the litany of pathophysiologic changes to the airways that happen with the passage of time, and the need for prompt intervention, early recognition, and early initiation, which involves everyone here. My disclosures, similar to previous presentations, I do speak on behalf of all pharmaceutical companies and manufacturers within the country and create content for local, national, and international use for medical education. I'm an active consultant and advisor for all pharmaceutical companies in the country. We'll start with the case. This is a patient of mine that actually I've had in my practice for a number of years, and actually spoke with him on Monday of this week. 24 years young, long-standing history of underlying asthma. Technically, we would consider this severe asthma because he requires Symbicort 200 maintenance and reliever therapy for control. He is compliant with it, takes 2 puffs twice a day, rinses his mouth, has it with him, and uses it when he feels that he has uncontrolled symptoms, which is approximately now 2 to 3 times a week in a bad week, which tends to be maybe 2 weeks out of the month. Baseline lung function testing was normal, but demonstrated what I would still consider to be a significant bronchodilator response reflecting an element of uncontrolled airways disease. This was his lung function testing recently performed at the Scarborough Health Network Centenary site. On the surface, he walked in with a vital capacity, the amount of air that he could blast out in that first second, of 88% in total. And in the first second, the amount of air he blasts out is 88% as well. His ratio is well above the lower limit of normal, well above that number of 0.7 that we hammer into your heads as obstructive physiology. But lo and behold, when we gave him 4 puffs of Ventolin during the test, having used Symbicort that morning, he still had a significant improvement of lung function, essentially half a liter of improvement of FEV1 and 12%. This pulmonary function test re-diagnosed him with underlying asthma and demonstrated that Symbicort maintenance and reliever therapy perhaps is insufficient for complete obliteration of underlying airways inflammation. But there was more to the story. He told me that he was frustrated of late. He has seen his ENT at SHN, and he had noted worsening of nasal disease and nasal polyposis. He does have chronic rhinosinusitis with nasal polyposis. He is on a complex regimen from his sinuses, nasal rinses twice a day, Rialtris twice a day, and Blexten, and it's no longer effective. They added budesonide nebules to his nasal saline rinses once daily, and it has mitigated the ongoing progression and worsening. But did it improve his disease burden? It's not getting worse, but it's also not getting better. He sees gastroenterology at the SHN. He has new GI symptoms with respect to food bolus impaction. There's a fear of eating certain foods because of concern of impaction and worsening esophageal symptoms with established eosinophilic esophagitis. Winter was rough because the cold weather in winter, indoor humidity issues led to worsening skin irritation, flare of his eczema, atopic dermatitis, and I have to say, he is not looking forward to the hot, humid summer weather. I appreciated his frustration. He was frustrated. He was relieved that he could talk about all of this because multiple organ systems are involved, and he is seeing myself, he is seeing dermatology, he is seeing allergy, he is seeing gastroenterology, as well as our rhinology colleagues. Prednisone, within 48 hours, dramatically improved all of those symptoms, however. Sinus, dermatologic, respiratory symptoms, but he was cognizant of the side effects. He read the pamphlet and he discontinued it after the third day. He wanted to feel better, but not take it so long that he suffers consequences of the treatment itself. I explained to him the unifying diagnosis. This gentleman, unfortunately, has T2 disease. And what I'm going to highlight to you is the ever-present tentacles of T2 pathology that involve multiple organ systems, and a unifying diagnosis and unified pharmacologic therapy with biologic can target all of these comorbid manifestations of disease. I would be at fault if I didn't talk to you at every visit about the double-edged sword and necessary evil that is prednisone and the impact of uncontrolled lung disease. So even though this gentleman has baseline lung function that is normal and has a significant bronchodilator response. That significant bronchodilator response indicates uncontrolled airways inflammation. It indicates an element of uncontrolled airways hyperresponsiveness, and it indicates that Symbicort maintenance and reliever therapy is insufficient for management. Follow patients with uncontrolled airways hyperresponsiveness, uncontrolled respiratory symptoms, and they exacerbate. And those exacerbation events are associated with an accelerated rate of decline of lung function. The group in gold, regardless of entry into this 20-year cohort study, has 2 or more acute exacerbations of asthma per year and sees an accelerated rate of decline of lung function compared to peers with absence of exacerbations in blue, or at the most 1 event in red. Now, I want to focus on youth here because the patient that I'm describing is 24 years young. Youth brings with it resiliency and reserve, but physiologic reserve is finite. And if you exhaust it, you exhaust your capacity to deal with more in the future. And what is heartbreaking for me as an adult respirologist is the 24, 36, 42-year-old individual coming to me saying, look, I've had asthma my whole life. And now, because of my asthma, I cannot do the following things in my job. I work with my hands, I work with my body, I work in a position where I need this machine of mine to function on all cylinders every day for me to pay the bills, pay debt, do my job. And the consequences of uncontrolled asthma exacerbations over the years, eroding that reserve, leads me to a situation where fundamentally that person has lost lung function that I cannot get back. Chance favors the prepared mind, and early intervention, early escalation, and aggressive treatment early on, I would say even going back to childhood and pediatric respirology, can alter that trajectory for the future because we do not reach full lung size until about age 18 to 22. So aggressiveness when one is young can help to mitigate downstream complications. But exacerbations are associated with a faster decline of lung function. The y-axis here indicates all-cause mortality risk. The x-axis is broken down into 3 tiers of lung function based on severity. Easy to see that the higher the degree of lung function impairment, mild to moderate impairment, or severe impairment, the greater the risk of mortality. Lung function decline is associated with an increased mortality risk associated with death in the context of asthmatics with poor lung function. This reduces your ability to manage exacerbations, to cope with triggers, to deal with the consequences of uncontrolled airways disease and airways inflammation. And of course, when one has an asthma exacerbation, we treat it with prednisone. And prednisone is that necessary evil. It is like radiation. There is no safe dose, but we irradiate patients every day because the benefits outweigh the risks. The benefits are greater than the harms. But there is no denying that there's a cumulative impact of harm associated with prednisone. And whether you're looking at a metabolic, a musculoskeletal, endocrine, cardiac, ocular, gastrointestinal manifestation, head to toe, higher degree of cumulative lifetime exposure leads to those consequences. Asthma exacerbations of COPD are not exacerbations of vasculitis. You do not need high levels of steroid. You do not need potent inhaled, potent intravenous steroid. Someone unfortunately is not on mute. If you could kindly mute, that would be great. There we go. I have taken care of it. Problem solved. If only asthma exacerbations could be solved as easily as that, but nevertheless we have to use prednisone. Getting back to the point of prednisone use, asthma and COPD exacerbations are not flares of vasculitis. You do not need whopping doses of prednisone. Think of it like a fire. A fire is burning. You take a carbon dioxide fire extinguisher, it extinguishes the flames. The heat is still there. The smoldering is still there. Prednisone will obliterate the inflammatory cells driving the exacerbation of asthma, driving airways inflammation. But that inflammatory milieu is not steroid responsive. It takes time for it to be unraveled, and that time to unravel is the immune system shutting that down in a non-steroid responsive manner. 125 milligrams, 250 milligrams of Solumedrol Q8 is overkill and drives these patients to higher side effects. Cumulative side effects begin to occur at a higher rate if you have more than 500 milligrams of lifetime steroid exposure. 40 milligrams of prednisone for 10 days, you're already at 400. So be diligent when it comes to prescribing steroid in the hospital because it's going to take time. It needs steroid, but more steroid doesn't mean less time required. And of course, higher dose of prednisone, higher cumulative dosing has a mortality risk. My wife has asthma. She has never utilized prednisone in her life. Following her and other non-users of prednisone, we would see an overall mortality of about 3% over 20 years in an asthmatic non-prednisone cohort. But for those who have had more than 2 grams of cumulative lifetime prednisone exposure, the y-axis here is not risk of mortality, it is the number of deaths. And 6-fold higher deaths are noted at around 18% at 2 decades. 18 out of 100 of those individuals are no longer with us. All biologics that we have in respiratory medicine reduce exacerbations. If you want to go back to 2024, to the first major biologic that we have in the modern era, Nucala, we see a 53% reduction of clinically significant exacerbations of patients on biologic compared to placebo. This was followed by Fasenra in the Sirocco and Kalima studies, where we saw a 51% reduction of exacerbations for Fasenra, known as benralizumab. This was followed by the Liberty Asthma Quest study for 2 doses of Dupixent, again showing a 50% reduction of exacerbations on biologic, published in 2018. And the most recent Health Canada approved kit on the block is Tezspire in 2021 from the New England Journal, showing a 56% reduction of exacerbations. All biologics work to reduce exacerbations of asthma. But we have to understand that in T2 disease, there are a number of inflammatory pathways. If you go back to medical school immunology, this, and depending on your vintage with respect to how long ago that was, this milieu of underlying inflammatory pathways that lead to asthma exacerbations, asthma-related inflammation, and pathophysiologic epithelial dysfunction has become more and more refined as we understand the mediators that drive this. There are epithelial level drivers, such as TSLP, that lead to downstream signaling when the epithelium is alarmed by an allergenic, pathogenic, pollutant, or irritant compound. There are humoral factors such as IL-5 that circulate throughout the body, IL-4 and IL-13 that drive cells of the immune system that lead to worsening asthma-related pathophysiology. T2 disease refers to mediators that you're already familiar with. IgE, produced by plasma cells when they're driven by IL-4 to specialize in the production of IgE, leading to mast cell activation and degranulation and that histaminergic allergenic response. Eosinophil maturation, also driven by IL-4 and IL-5, leading to mucus plugging, airways remodeling, epithelial dysfunction, as well as fractional excretion of nitric oxide, and the remodeling component driven by IL-5, IL-4, and IL-13. There are various targets that biologics have with respect to targeting these pathways. Not all of them are the same in the sense of some biologics target some pathways and others don't. This is beyond the scope of a presentation for this group. This is for your friendly neighborhood respirologist, friendly neighborhood allergist, and dermatologist to know. But I'm going to show you as we get on with the presentation that we need your eyes, your ears, and recognition of underlying the comorbid patients to help us guide and initiate treatment in patients to change and alter these pathways. The beauty of biologics is that we can shut down these pathways to the point that we can start to unravel and reverse the consequences of uncontrolled T2 disease. And I'll show you data with respect to mucus plugging, airways hyperresponsiveness, airways remodeling and fixed airways obstruction, and some of the benefits that we see in asthma and COPD. Universally, I want to show you the content and show you the criteria for treatment. All patients from an asthma standpoint with biologic require a high-dose controller, meaning a high-dose inhaled steroid, plus another controller therapy, almost always a long-acting beta agonist. So if you think of your patient on Advair 500, Brio 200, Symbicort 200, like in the case, those are qualifying inhaled therapies. Biologics have different requirements with respect to peripheral blood eosinophil count. If you share this with your friendly neighborhood respirologist, allergist, or dermatologist, it is icing on the cake. All of us have access to Connecting Ontario. All of us have access to Epic by virtue of being at the hospital and in the hospital system. We can find these blood work values and sort through this ourselves. But the key requirement is a history of exacerbations. Drugs like Nucala and Fasenra for public coverage require 2 exacerbations that are moderate or severe, moderate meaning prednisone as an outpatient, severe meaning prednisone in the walls of a hospital, even the emergency department. Dupixent is unique in that we have public and private coverage with a single exacerbation, be it moderate in our office or severe in the hospital. Now, our colleagues at GlaxoSmithKline and AstraZeneca for Nucala and Fasenra help us bridge patients that have not had 2 exacerbations, but getting someone on publicly funded or private payer coverage is important, and Dupixent is unique in that it requires only a single exacerbation event at a lower threshold of eosinophils. Average cost, you'll ask, is about $2,000 per month. However, there are, of course, negotiations and confidential pricing between public payers, private payers, and the manufacturer. This is the headline publicly available price from the Exceptional Access Program. I alluded to this, and I'm showing it to you graphically, that when we're looking at type 2 inflammation and asthma, we have different phenotypes. We have the typical allergen-driven elevated IgE and fractional excretion of nitric oxide airways inflammation. On the far right-hand side, we have the pure eosinophilic, elevated peripheral blood eosinophil count, elevated fractional excretion of nitric oxide. But there is a high degree of overlap in the middle. Life is not always clean for one camp or another. There is a lot of gray that sits within the middle. And this is not insignificant. If we take the International Severe Asthma Registry and look at these biomarkers of eosinophilic, allergic, and let's call pure type 2, which is airways epithelial inflammation driven by IL-13 manifested in a fractional excretion of nitric oxide respiratory test. About 60% of patients in this registry have an elevated biomarker that fits into one of these camps. But of those patients, 2/3 to sometimes 3/4 had concomitant elevation of another biomarker of T2 disease. In fact, 60% of patients had 2 or more elevated biomarkers. This is a heterogeneous disease of multiple biomarkers being elevated, multiple pathways being elevated at once. You want a biologic to cover many different manifestations of T2 disease because different biomarkers reflect different manifestations of the disease in different organ systems. So let's talk about a common organ system where lower respiratory disease burden in the setting of asthma and upper respiratory disease burden in the setting of chronic rhinosinusitis with nasal polyps. This is very well established. If we take patients with CRS with NP, chronic rhinosinusitis with nasal polyposis, well in the domain of our friendly neighborhood rhinology colleagues, 80% of those polyps are actually type 2. The minority are going to be type 1 and sort of irritant epithelial dysfunction leading to a non-type 2 polyp. But 50% of those patients with moderate to severe CRS with NP who would be biologic candidates have concomitant asthma. If we look at asthma at the bottom here in orange, about 50 to 84% of asthma is type 2. And 30 to 40% of those severe asthma patients who would be biologic eligible have coexisting CRS with NP. There is an established relationship between what's happening in the upper airway and the lower airway. Indeed, we call this the United Airways. And if you're not a fan of United Airways, perhaps you like to fly Delta, but you cannot deny that the United Airways is a pathophysiological manifestation of type 2 inflammation affecting the upper and lower airways. Our allergy and ENT colleagues will say that the nose is a part of the lung that you can touch with your finger. I'll pause here to allow you to laugh so that I can then carry on, but it's a part of the lungs that you can touch with your finger, indicating that what happens pathophysiologically in the upper airways is reflective of what's happening in the lungs in the lower airways. Epidemiological, clinical, and pathophysiological studies show that these coexist, that upper airway inflammation and CRS with NP, the lung that you can touch with your finger, and the lower airways, the traditional lung, have a pathophysiologic connection and an interaction. I see this as an adult respirologist purely based on gravity, because what happens in the upper airways drips down continuously into the lower airways, even when you are asleep. But pathophysiologically, the processes are similar. And the data demonstrates that in our patients with CRS with NP, 2/3 have coexisting asthma. A quarter have exacerbated respiratory disease upon exposure to a non-steroidal anti-inflammatory drug, and up to 80% have coexisting allergic rhinitis. What happens in the upper airways is pathophysiologically related to the lower airways. And this has an impact because when you have asthma and chronic rhinosinusitis with nasal polyps, you have difficult disease that requires very diligent management because it is difficult to control. Our rhinology colleagues will state and complain that these patients have a greater need for revision surgery. You know, when you go in and operate on the sinuses and you do your diligence and you clean that sinus passages and those cavities out with a diligent resection in the setting of chronic rhinosinusitis with nasal polyps, going back in is often a challenge. It's often messy. And fruitfully, for the patient, they may not see the same degree of relief with a revision surgery. But pathophysiologically, asthma and CRS with NP means a greater need for it. These patients are more exacerbation prone. They have a higher degree of airway obstruction. They use more oral corticosteroid. They have a higher burden of inflammatory milieu with blood and sputum eosinophils, IgE, not listed here, and fractional excretion of nitric oxide. At any point in time, asthma and chronic rhinosinusitis with nasal polyps means a higher burden of exacerbation in terms of exacerbation rate. That is essentially one exacerbation per year higher than asthma without that nasal disease. So if you see a patient with severe asthma in the emergency department, in the general medicine clinic, in your office, on a hospital ward, and you are a bedding person, other T2 disease is coexisting. The real world is far from ideal. And if you ask, and I speak to and advise respiratory specialists and family physicians across our country, if you speak to colleagues across the country, how many of us have a chance to look in the nose? It is less than it should be. How many of us look at the skin to assess for atopic dermatitis? Some would say only in the summertime because that's when it's simply available to me, not in winter. Life, unfortunately, means that sometimes we stay in our lane because the demands placed upon us make it challenging to think about the other organ systems. But let's think about this for a second. When I have a patient in front of me with severe asthma, I know that statistically, that patient has a 30 to 40% chance of having clinically significant chronic rhinosinusitis with nasal polyposis. I know that there's a 1 in 5% chance that they have EOE, eosinophilic esophagitis. And a huge source of referrals to our gastroenterology colleagues for EOE actually comes from our emergency department colleagues of food bolus impaction. And I know that that patient does have a 5 in 100 risk of having that condition where meaningful food bolus impaction can occur. Up to a quarter of these patients will have atopic dermatitis, a sizable proportion, NSAID-related ERD, and food allergy. Sometimes we don't have the time to tease out the comorbid conditions present in the setting of severe asthma. But knowing this data arms us that if I see severe asthma in front of me, severe eosinophilic allergenic asthma resulting in an exacerbation warranting ED visit, general medicine clinic visit, or hospital ward admission, there is a reasonable probability that this patient has other T2 disease manifestations with CRS with NP, atopic dermatitis, and eosinophilic esophagitis that can be addressed with biologic therapy. So we've talked about the pathways of T2 disease, and I want to focus on a biologic known as Dupixent that has a number of Health Canada indications for treating manifestations of T2 disease. Dupixent targets two different aspects of the type 2 inflammatory pathway. By IL-4 blockade, we block eosinophilic maturation, we block B-cell maturation to IgE production, and we also block the allergenic inflammatory cascade of innate cells, the basophils, and the mast cells, those cells that explode on contact in the context of underlying allergenic exposure. But we also have an effect on local inflammation at the level of the epithelium. By blocking IL-13, not only do we decrease mucus hypersecretion and epithelial dysfunction, but we unravel the impact on smooth muscle hyperresponsiveness and smooth muscle contractility. There is a systemic and local anti-inflammatory effect. Now, Dupixent has approval for not only severe asthma and COPD, and I'll touch on the data from those studies, but beyond the scope of this presentation with respect to the raw data, but definitely in the setting of T2 disease, Dupixent is approved by Health Canada for management of chronic rhinosinusitis with nasal polyposis, eczema, atopic dermatitis from age 6 months of age for atopic dermatitis onwards, eosinophilic esophagitis, asthma, and COPD, as I mentioned, prurigo nodularis, which I will say is definitely within the domain of our dermatology colleagues and beyond our scope in general internal medicine, as well as subspecialty respirology. But the number of manifestations of T2 disease from CRS with NP, atopic dermatitis, eosinophilic esophagitis, asthma, and COPD that Dupixent blocks is a reflection of the presence of IL-4 and IL-13 activity in these disease processes under the umbrella of T2 disease. Liberty Asthma Quest, I already showed you the punchline from 2018 with respect to this study, looking at Dupixent at 2 doses in patients with a history of severe exacerbating asthma. These patients had a history of 1 or more exacerbation of asthma requiring systemic corticosteroid therapy or emergency department visit or hospitalization. And moving through this to look at the patient population, the average FEV1 was 58% in the study. So while, of course, about 30% lower than the patient case that I highlighted at the start, these patients had quite significant respiratory disease. The presence of severe impairment of FEV1 is not a requirement for biologic. At any level of FEV1, one is biologic eligible for the setting of underlying asthma or COPD based on criteria. 51% of patients in this study were on high-dose inhaled steroid, but look at the comorbid nature. 82% had underlying atopic or allergenic condition. A quarter of patients had nasal polyposis or chronic rhinosinusitis. Blood eosinophil count on average was 0.36. IgE was elevated at 432, with the upper limit of normal being 240. You've seen this in the overall patient population of intention to treat, but I want to show you what happens when the patient has a higher manifestation of T2 disease. Peripheral blood eosinophil count above 150 versus above 300. A higher numerical reduction of exacerbations was noted in the setting of treatment with Dupixent. Epithelial dysfunction with respect to IL-13 driven fractional excretion of nitric oxide, a higher burden of exacerbation reduction was noted with patients on Dupixent, even at the lower dose. The overall population demonstrated about a 48% reduction of exacerbations on dupilumab 200. But the higher burden of T2 disease, you see exacerbation reduction pushing into the high 60, 70% range. Indeed, if we're looking at lung function improvement here, with the bars vertically demonstrating improvement of FEV1, the amount of air the patient can blast out in the first second, a key reflection of airway caliber, the higher the burden of T2 disease by peripheral blood eosinophil count or fractional excretion of nitric oxide, the better the response. The more T2 you are, the greater the benefit that Dupixent has of addressing that pathophysiologic process and unraveling it to reverse the manifestations and improve lung function and exacerbation rate. Let's go well above eosinophil count of 300. Let's only look at the patients that had a peripheral blood eosinophil count of 500 or more at baseline. We see a 74% reduction of exacerbations. Total population, 48%. Eosinophils over 500. The more T2 you are, the greater the benefit that we see with Dupixent. Even if we look at lung function improvement compared to the 300 mils that you saw for patients that were T2, but now with eosinophil count over 500, we see over a 500 milliliter improvement from baseline, over 300 milliliters compared to placebo. Now, the beauty of the QUEST study was that it had a 2-year follow-up, which is almost unheard of in respiratory phase 3 clinical trials, actually phase 3 clinical trials in general, because these are expensive to run. So they had a 2-year extension. Now, I always say that chance favors the prepared mind, and don't put off to tomorrow what you can do today. If a patient was randomized to placebo in red during the 52-week RCT called QUEST, when they entered the extension study, they caught up. Lung function within 2 weeks of someone who had 1 year of placebo injections equaled that of a person who had been on Dupixent from the start of the QUEST study. They did catch up. But catching up is a blessing in that when you start Dupixent, that patient will achieve benefit, that benefit will be preserved, it will be long-lasting as demonstrated here over 2 years, and 3 years for those who were on treatment from the beginning. But that saying of chance favors the prepared mind is primarily around reversing the morbidity of disease. And for that, much like investing for retirement, it's not timing the market, it is time in the market. And time on biologic, being on biologic for a longer period of time, pays dividends. One dividend here, looking at persistent airways obstruction. I apologize, this is a complicated slide. It's here for your reference, but I'm simply going to focus on the left-hand side. If we take patients in the Liberty Asthma Quest Severe Asthma RCT, and we look at patients treated with Dupixent, whether we're looking at group A, where blood eosinophil count was over 150, or FeNO was over 25, or group B, where they were sicker, with blood eosinophil count over 300 and FeNO over 25. Green indicates Dupixent, black indicates placebo. The y-axis is persistent airways obstruction. You receive consult notes from your friendly neighborhood respirologist that this patient has baseline and post-bronchodilator airways obstruction in the setting of asthma. They have fixed obstructive lung disease. We throw high-dose inhaled steroid, high-dose triple therapy, oral prednisone at these patients to try to reverse this, and it doesn't budge. We think of this as a static fibrotic narrowing of the airways. In patients treated with Dupixent, we saw a doubling to a tripling of resolution of fixed airways obstruction compared to placebo. Years ago, management of rheumatoid arthritis with a drug called Enbrel, one of the first biologic used to treat rheumatoid arthritis. We noticed patients with rheumatologic disease having granulomatous changes within the lung. All of a sudden, when you treat them with a TNF inhibitor, those granulomatous changes, those calcified lesions, they melt away. What we thought was a calcified prison for bacteria, fungus within the airways actually was a dynamic structure, and with blockade of one signaling molecule in one pathway, those granulomatous changes melt away. Unfortunately, tuberculosis comes back, but we know that it's not a static structure. We're entering the era where asthma and fixed airways obstruction may not indeed be a static, fibrotic narrowing of the airways. The data from QUEST demonstrates a 2 to 3-fold increase in the likelihood of resolution of fixed airways obstruction reversal of what was thought to be fixed, irreversible remodeling. Along the lines of time on drug, I want to show you what happens after 3 years of Dupixent. Patients who received Dupixent during the 52-week clinical trial in the year prior to admission to the trial had 2.12 exacerbations per year. So you can equate this to somewhere between 500 to 700 milligrams of prednisone per exacerbation. These patients are already out of low risk in the year prior to trial enrollment. During the 1-year, 52-week study, they went from having 2.12 exacerbations in the year prior to 0.48 exacerbations. And after the second year of follow-up and the third year of follow-up, 0.27 exacerbations per year. These patients on drug went from having 2 exacerbations per year to 2 exacerbations per decade. That is a profound attenuation of disease severity and trajectory alteration. If you were randomized to placebo during that 52-week RCT, 2.23 exacerbations went to 0.99 exacerbations. Everyone does better with good subspecialty respiratory care. Exacerbation rate, exacerbation management improves, exacerbation rate goes down. But that patient randomized to placebo for the RCT, after 2 years of Dupixent, has a rate of exacerbation similar to their peer who has been on Dupixent for 3 years. For the friendly neighborhood respiratory colleagues of mine in the audience today listening, and our colleagues that manage chronic disease with biologics, I relish the opportunity to start biologic at consultation appointment, the first visit with the patient. Because if you meet the criteria, if I can check the boxes off, what I'm doing is mitigating morbidity, mitigating prednisone exposure, and preventing downstream consequences. I'm still going to do my thing. I'm going to see that patient on a regular basis and manage that biologic patient until I leave this world, they leave this world, or one of those two occur. But at the end of the day, the sooner we can get the patient on drug, the better it is going to be. And all of us in chronic disease management, we tinker, we adjust, we have levers and switches that we like to move. In asthma, in comorbid T2 disease, adjust those levers, tweak those tweakables. But at the end of the day, all of that will be better if you do your thing, plus have the patient on a biologic. The take-home point from asthma before we switch gears to COPD and the second part is that these biologics are life-changing medications that prevent and for some eliminate exacerbations. They improve lung function. They enhance quality of life. For some, they resolve fixed airways obstruction. Not all of the biologics have the power to address multiple manifestations of T2 disease, but universally, from atopic dermatitis, eosinophilic esophagitis, prurigo nodularis, chronic rhinosinusitis with nasal polyps, asthma, COPD, the T2 manifestations that we see in disease in real-world clinical practice are addressed with Dupixent injections. Prednisone is a necessary evil in the setting of exacerbations. More is not better. More does not further attenuate the consequences of T2 inflammation any better than less or enough steroid. But please, there is no safe dose. The consequences of prednisone are indelible. And you must recognize that this is a lifelong consequence that that patient will experience with higher dosing of steroid. We can initiate biologics in the setting of a severe asthma history with exacerbations. We need an asthma diagnosis. We need the patient on one of your friendly high-dose ICS plus LABA or high-dose ICS plus LABA-LAMA. The usual suspects are listed here. I will tell you what comes to mind when you say, I'm going to treat asthma with this, is very likely a high-dose ICS. It is not Trelegy 100. It is not Breztri. Those are COPD doses. It is your Trelegy 200, your Enerzair 160, which we have on formulary at the SHN, Brio 200, Symbicort 200, Zenhil 200. If you prescribe prednisone to a patient with asthma or COPD, Respirology needs to see that patient. I highly recommend having us see as an inpatient so that we can see, assess, establish the connection, populate the after-visit summary, and increase the likelihood that not only will the patient come to see us in the office, but also that we emphasize that What brought you here? I'm here to talk about that so that I can start something to change that. The goal in respiratory disease is trajectory alteration. The goal is timely intervention with optimal therapy to maintain disease stability. It's an ambitious treatment goal. It is achievable in asthma that we can see absence of exacerbations, absence of symptom worsening, absence of deterioration of lung function. It is the dream in COPD, and we are moving towards that with multimodality therapy in the setting of COPD. COPD is a different beast. I could spend 2 hours on a presentation of contrasting and comparing the beast of asthma versus that of COPD, but it is a disease that is more heterogeneous in terms of its pathophysiology and in terms of the targets that we can treat. And it also is, unfortunately, by definition, permanent, fixed obstruction. And that obstructive process of why someone with current or former tobacco history develops COPD and another person doesn't, you win the Nobel Prize if you can tease this out. The goal is disease stability. The goal is absence of trajectory altering symptoms, lung function, or exacerbations. All of us know that single inhaler triple therapy is the recommendation for symptomatic exacerbating patients. In the modern era where medicine is event-driven, task-driven, patients complain about something, and that complaining about something is often something happened, I had an infection, I feel worse, I have deteriorated, I had to go to the ED at insert hospital name here, and now I'm back to see you. Single inhaler triple therapy is the first, the only, the final treatment for those patients. If you tell me that all of your patients with COPD are on single inhaler triple therapy, I don't fault that, because even for patients without a frequent exacerbation history, many will naturally escalate to triple therapy because their symptoms are uncontrolled on dual bronchodilator therapy, like Anoro or Inspiolto. I've spent time on this flowchart in a previous presentation, so I won't take as much time. But I'm going to highlight where the biologic sits when the person is on single inhaler triple therapy and they have that next exacerbation event. But first, I want to take a step back and highlight some features that you may not be familiar with. Mucus plugging. When you enter the emergency department in a North American, Western European hospital, you enter sideways and supine and get an automatic CT pulmonary embolism protocol, because it is a very good screening tool for everything, and it is utilized by our colleagues managing falling knives very appropriately, because there are a lot of life-threatening conditions that can be excluded with detailed radiologic assessment of the thorax. I don't fault this, but it's also helpful at the same time because CT scans demonstrate mucus plugs. Mucus plugging doesn't correlate necessarily with chronic bronchitis phenotype. A patient can say they're dry as a chip, but have radiographic mucus plugs reflecting epithelial dysfunction. But they can also have copious chronic bronchitis phenotype and mucus plugging. If you count the number of lung segments, I'll spare you how many segments we have, but the radiologist knows and our respiratory colleagues know the number of segments we have. And if you just count the number of segments on a single CT scan that a patient with COPD has and follow that patient for 12 years, there is a correlation of the number of mucus plugs and the number of segments and mortality. 0 plugs, yes, these patients still die. 60% of patients dying, 40% of patients on the y-axis dying at 12 years with no mucus plugs. But 3 or more segments involved with mucus plugging, and that's a 60% likelihood of death at 12 years. 3 or more. Now, what's fascinating is that on the right-hand side, if you look at, in blue, lung function severity, gold stage on the y-axis, and mucus plugging on the x-axis, you don't see a strong correlation. You would expect greater spirometric severity of COPD means that this box over here has the highest number of mucus plugs. This is actually a bit of a miss, a bit of a mess. We don't see a correlation from bottom left to top right of greater spirometric severity, higher degree of mucus plugs. But when you combine spirometric severity of COPD and mucus plugging, you see a strong correlation. Our severe and very severe patients with mucus plugging on CT scan can look forward to a 60 to 80% risk of mortality over that 10-year window. There is a correlation here, folks. Mucus plugging reflects epithelial dysfunction. Epithelial dysfunction drives exacerbation rate, and a higher spirometric severity of COPD means less resiliency, less ability to cope, higher likelihood of mortality. We know that peripheral blood eosinophil count also correlates with a higher likelihood of decline of lung function. The y-axis here is lung function, the x-axis is follow-up. A higher peripheral blood eosinophil count and a greater the degree of decline of lung function. Up until biologics and COPD, this is all we had. We had single inhaler triple therapy. We had chronic azithromycin, which unfortunately leads to increased risk of tinnitus and subjective hearing loss, increased likelihood of cardiac arrhythmia, and also resistance to non-tuberculous mycobacteria and microbial flora in general. And honestly, the relative risk reduction of 27% in a study from 2011 where only 50% of patients were on standard of care that we would consider single inhaler triple therapy, hard for me to look at the external validity of this study. Even worse, roflumilast, Daxis, first of all, in this economy, it's not covered. It's $90 a month. It is a challenge for this patient on fixed income, like 85% of our patients with COPD over the age of 65 on government support. Average CPP payment in Canada is a little under $800 a month. 10% of their CPP going to Daxis is not tenable in this economy. And plus, the external validity is challenging because this is from 2009. These patients weren't on inhaled steroid to begin with, and the reduction of exacerbations was a measly 17%. It's better than nothing. Multimodality therapy helps, but the biologic era. The Notice and Boreas clinical study took patients 40 or older, 2 or more moderate or 1 severe exacerbation of COPD, moderate to severe COPD, FEV1 between 30 and 70%, but that's not a requirement. Lung function is not a requirement for drug in the in terms of getting access to drug. They had to have a history of T2 inflammation, which means peripheral blood eosinophil count of 0.3 or higher, randomized to placebo or Dupixent. Bottom line, improvement of lung function was noted, 83 mils. That's helpful. It improves lung function. It slows the trajectory with respect to the number of years it will take to lose that additional lung function. The more you gain, the more reserve you have, but that's not the reason I'm prescribing a biologic to a patient with COPD. It improves quality of life for a disease that is incurable and robs the patient of their independence and quality of life each and every breath they take. Improving that is a meaningful outcome. It is something very noble and meaningful that I prescribe a biologic for. But you know where I'm going. The main indication is exacerbation reduction. And we see a 30 to 34% reduction between 2 clinical trials of moderate or severe exacerbations. When you're thinking of biologic eligibility for your patient with COPD, there are easily established criteria. My call to action is that every patient admitted to our hospital system or emergency department or general medicine clinic with an exacerbation of COPD should be co-managed by respirology. We should see them in hospital, establish that connection, follow up as an outpatient, and please, for our MRP colleagues listening, refer the patient to the COPD clinic. If you suspect COPD for a patient in your practice, I'm going to show you just in the last couple of minutes how to order a PFT through Epic and have that PFT performed, because now all of us have the ability to order a pulmonary function test, even if you are not a friendly neighborhood respirologist. The criteria for starting Dupixent for patients with COPD is straightforward. You have to be on triple therapy, which quite frankly is the background therapy that many of our patients find themselves on. You have a blood eosinophil count of 0.3 or higher in the past year. If you see this, tell us. If you don't see it or don't have the time to see it, don't worry. We can find this. They have to have a degree of dyspnea such that hurrying on level ground or climbing a gentle hill, they have to experience dyspnea, but they don't necessarily have to stop. Truthfully, even some of us here, hurrying on level ground or climbing a gentle hill, will experience dyspnea that doesn't require us to stop. But they have to have an exacerbation history. 2 or more exacerbations treated as an outpatient, but even 1 exacerbation through the walls of our hospital, and you qualify for Dupixent. Every time I see a patient that's pulled the trigger on the action plan of prednisone, I ask myself, is this patient biologic eligible? And when I check off these 5 boxes, even at the first consultation visit, I've established that they're biologic eligible. I'm going to do my thing. I'm going to see the patient and continue to manage them forever and ever. But at the end of the day, everything I do plus a biologic is better than everything I do. Lastly, last couple of minutes, the pulmonary function lab is open. We are running 28 pulmonary function tests per day with a high throughput for respiratory assessment. I have some scenarios here. If you're in your office and your patient is currently an outpatient and you want to order an outpatient PFT, move over to the orders tab in Epic. Using add order, you'll be able to search for pulmonary function test. If you search for pulmonary function test, you'll capture it. The short form is PFT 13. Once you click on PFT 13, you'll be asked to select the future status. That should be default as future. Specify when you want it. If the patient in front of you says that, my breathing tends to be worse at this time of year, and you want to reassess their asthma or COPD at that time of year on their treatment, then please select the time that you would like that pulmonary function test performed. The one red exclamation point in the red circle is for the type of procedure. This is also straightforward. When you click add, you simply have to look for the first test, complete pulmonary function test. And if your reason for the pulmonary function test is diagnosis of asthma, diagnosis of COPD, write it in the comments. If you want the patient to continue treatment for the test because you want to reassess their asthma, reassess their COPD, write it in the comments. Continue inhaler therapy for testing. The booking people at CPS will be able to schedule that. Let's say you're an inpatient and you want to order an outpatient PFT. Under orders, migrate over to future outpatient and repeat the same process. Under future outpatient, select the pulmonary function test, and it will show up as an additional discharge order where you can select future, specify when you want it to be, specify that it's in the complete pulmonary function test, and add any comments that you would like, if it's with or without treatment, and they will have a full pulmonary function test. If your patient is an inpatient and you want an inpatient PFT, this is a no-go at present. It's restricted to the outpatient setting, but please consult the inpatient respiratory service. For example, our colleagues at SHN at the Centenary site who need to send a patient for cardiac surgery may need a pulmonary function test because the vital capacity is demanded by anesthesia and cardiac surgery. We can do bedside spirometry. We can give values that are meaningful and have to answer the clinical question and not necessarily a full pulmonary function test. We have access to bedside spirometry at all 3 sites. Please consult Respirology. You can also consult the respiratory therapist, but in these types of situations, both is helpful because we can all 3 of us discuss. If you want a paper form, the paper form is available and you can get this through the SHN website. You can also access this through Oceans as well. It's coming to Oceans soon, but there is a version on Oceans. And you can select your preferred test with respect to the reason for testing, the scheduling preference, and truthfully, all we need is routine scheduling checked off. Why you're ordering it, you can skip the history and current treatments. Our respiratory therapists ask these questions and identify the test that you want. And from my perspective, order a full pulmonary function test, a complete PFT. Referral to the COPD clinic at the Birchmount site is this future outpatient discharge order to the Central East Hospital Respirology Clinic. You would click internal referral, the SHB COPD clinic, answer the questions truthfully. Also add in the spirometry order, the RESP 13, which is the next order that you will add in. And once signed, that patient will be referred and see a friendly neighborhood respirologist at the Birchmount site in clinic. I do have some smart phrases under my name. If you want to populate the after visit summary patient instruction section with some key phrases for the Birchmount COPD clinic, for any radiologic investigations, for information on the pulmonary function test, I have these smart phrases for you to copy and borrow and utilize. I often find myself saying, if I do something 3 times in a row, I'm going to create a smart phrase or a macro out of it so that I don't have to repeat myself. If you want to prescribe N-acetylcysteine, refer them to the Center for Addiction and Mental Health Nicotine Dependence Clinic downtown, which is self-referral. There's a smart phrase for that. Also for aerobica mechanical chest physiotherapy. I am at time with the last slide. I'll stay on if anyone has any questions, but otherwise, enjoy Wednesday, enjoy the rest of the week, and looks like no more snow from here on until the end of the year. Have a wonderful day, everyone.
Dr. Bhinder, I was waiting for everyone to leave, but are you able to share your slides with us? Because I think
Oh, yes, of course.
some of the
Of course.
pharmacy group that wasn't able to attend today, they would really benefit from.
Yes, 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 I will. I'll attach it and I'll email it to Megan and I'll email it to yourself as well.
Okay, thanks. I know this is recorded, so we can always go back and watch it later as well. Thank you so much.
You're welcome. Okay.
Bye-bye.